Bueno, vamos.
Okay, so let's start our afternoon session. We have Dr. Antonio Tugores, who will be our next speaker. Well, good afternoon. I'd like to thank the organization for their invitation. It's an honor for us. We that work in the lab, we are involved with tubings and pipettes and all that, so it's an honor. So this is a bit of an atypical presentation. We are a tandem, the Dr. García-Villarreal and myself, and we will give a double presentation. I will do an introduction of the issues that we're dealing with lately, and then Dr. Villarreal will be talking about some of the data that we have been collecting. So, basically, as many of you will know, we work in Gran Canaria island. It's one of the places in the world that with the highest incidence of Wilson disease. So this is a priority for us to establish the screening before, so we can pick up people before the condition advances. And this is a challenge that I will be presenting today. So there is this decalogue of these 10 rules, basically established in a WHO document in 1968, these 10 rules. And this document establishes a number of requirements that I will be telling you. The condition should have an important health problem. It needs some treatment. The diagnostic and treatment infrastructures must be in place. There must be a recognizable pre-symptomatic stage, so this means that there is time to intervene. There must be an appropriate detection tool. The test must be acceptable to the population, being screened, not too invasive, and so forth. A good knowledge of the development of the disease should be available. A consensus must be reached on the criteria that define whether or not to be involved or affected. The cost of screening, including diagnosis and treatment of patients found, should offset the healthcare costs of no intervention. And finally, there must be a continuity strategy to follow up the results of these cases. I think these are the criteria that were established for this neonatal screening. An example that I came across of late is this Genomics England, that it gives us information about where we're standing, and this is a United Kingdom project. They are going to sequence about 100,000 newborns, and in that screening, basically, they're going to do the whole genome sequencing, and that's what they're going to do. And this assessment will be limited to a number of genes that meet the criteria that I just mentioned, the serious diseases with a biochemical validation form, and that genotype is complemented by an additional test. And I asked the Dr. Peak, who is the one that had laid out this subject in a conference, and I asked him whether ATP7B was in the list, and it is not in the list. Why is that? Well, we should highlight the importance of this complementary test or evidence, and I'll show you a gene that is on the list, the TAT gene. This is the tyrosine aminotransferase. Basically, they cause this tyrosinemia type 2 condition. So we sequenced this STAT gene, and we found there are 2 gene variants, and these could have been validated, and we know that patient validated mean that they've been found in patients that suffer these pathologies. So we know that those mutations will cause the condition. So we know that individual will develop tyrosinemia type 2, but we might find non-validated variants that they haven't been found in any patient, and maybe some programs that we use to predict those changes in proteins, they might or might not be pathogenetic. This is what we call uncertain sort of validation test. We need these tests to confirm whether that individual has the disease, and basically what we're doing is the tyrosine detection in blood, and these can be done during the when the child is born, rather. So our problem with the ATP7B is that we don't have that, and as we've seen, there is not a definite, concrete test that helps us to identify Wilson's disease in an asymptomatic stage during birth. So out of all these conditions, we don't have this appropriate detection tool. We don't know whether the test could be acceptable because we don't really have that test. And we also have many challenges to define, because diagnoses are complexes. Who is has the disease and who doesn't have the disease? And since we don't have a test, we don't have cost efficiency tests to make sure whether the screening is cost efficient, and then we don't have a continuity strategy to determine what are we going to do with a person that is asymptomatic. We don't know how to treat these patients. So, at present, what options do we have? Well, they're quite limited. We could perform a genetic testing of the most frequent mutations and a follow-up. Maybe we could measure ceruloplasmin and ATP7B gene sequencing for positive cases. We have the relative exchangeable copper, quantification of ATP7B in dry droplets, and measurement of free copper and ceruloplasmin. And I'll try to talk a little bit about these 5 modalities. The genetic test is great for the neonatal period. Also, it's suitable for isolated population, such as the Gran Canaria island. But, for example, in Sardinia, they've performed these type studies. This is another place in the world where we can find plenty of Wilson's disease. This is an accessible and cheap technology, but many cases are lost, and the cost effectiveness need to be assessed. Ceruloplasmin and ATP7B sequencing, we know that the screening should be performed at 2 or 3 years of age, where the levels of ceruloplasmin are stabilized. This technology is accessible, although the complete sequencing of ATP7B is not sufficiently widespread around the world. Ceruloplasmin is not always sensitive. Where do we establish the cutoff point, whether we are going to do this gene screening or not? And sensitivity will establish that. It requires blood collection, and so a 2-year, 3-year-old asymptomatic child, we have to draw this tube of blood. Is sometimes a challenge, and its cost effectiveness needs to be evaluated as well, or assessed. Well, the relative interchangeable copper, basically the REC, basically it's highly sensitive and specific, but not so much. And we've seen that in certain cases. We don't know how it behaves in asymptomatic individuals. It hasn't been implemented in the health system. It needs blood collection, and we need to determine the screening age. Cost effectiveness needs to be assessed as well. In terms of quantification of ATP7B in dry droplet, this is a methodology being developed by a United States company called Key Proteo, and we're working together with them for validation. It's in validation phase, feasible in neonates, but this is a complex technology, and it's in the hands of a private company, and we depend on a third party to perform this type of tests, and we don't know how much it's going to cost in the end. Also, some technology that was presented in Arrows in the last meeting, and that was very interesting. Alessia Titze, working in a university in Sweden, they've developed this device to measure with high sensitivity free copper to femtomolar, very, very low levels of copper. And this type of test also allows us to use like a glucometer. With just a droplet of blood, we can determine the ceruloplasmin and free copper amount. We could also have a ratio between the free copper and the ceruloplasmin that is reverted in between those who have and those who don't have the disease. But this is an unvalidated and developing technique. So, right, this is the technique that has been developed in this technology. And basically, right now, we don't know which one is the test that we could apply to this screening and which one would be the most convenient. So now my colleague Luis García-Villarreal will continue with his presentation. Well, good afternoon. Thank you very much to the organization for the great effort that you do year after year to make sure that we're all here. I see new faces, very happy. Also, thanks to Dr. Tugores, because it's gone very fast, so I do have some time. But anyway, we'll have some time for questions later on. Right, the presentation, until this point, you have been able to see that we're talking about screening. And by screening, I presented that last year. The one that we started last year, we've tried these again this year. We've had some issues with the cost effectiveness program, so I'll combine the cost effectiveness part and those things that were missing last year, penetrance and low or high penetrance. So basically making sure that which cases need to be screened. This is just an example to start with about how we are working to perform these cost-effectiveness cases in the health system to make sure whether investment is worth. This is how we work in the public health systems and also some private systems like the United States. We can see that, but this just represents the layout to show you that this is a tool. Once we end up the work with the other group that we work with in Spain, this tool will allow us to be applied in different geographies in Spain, in different regions that will be assessed in a different manner, because we will be able to introduce a number of variables modifying the final result. For example, one of the main factors is the age on diagnosis. Experts will tell you, I need many data, many clinical data in order to create this cost-effectiveness system. And we ended up like with 18 years old on average. This is what we find in the Gran Canaria island, but in Austria we have a different year. Globally in Spain we have a different cutoff age as well. And what we do is we try to estimate with this specific methodology the cost to the public health system to perform the screening to all the newborns, and I'm talking about neonatal screening in this first slide, and how much it would cost not doing the screening. So the information are provisional, since we'll have to adapt the methodology and the data and the group that will be working on that. But I'm interested on these graphs are quite new. This methodology allows this sensitivity study. Once all the data is on the IT system and the software, you can modify some variables and see how the value changes. So in some geography with a specific population, so Italy, Germany, or Austria, or Spain might have different characteristics and features. So the sensitivity cost, for example, this is a very important factor. The screening that I'm presenting, it's screening to all newborns. So, I mean, I'm sorry, we're talking about 3-year-old children. The speaker corrects himself. So we would determine a ceruloplasmin to the population, to the Canary Island population or whatever. If we have a lower level, we would perform a gene study. The determining factor in that model is the cost of the ceruloplasmin technique, because all of them are going to undergo those tests, but one every 3,000, 6,000 or whatever will undergo this gene test. As we can see here on the left-hand side on this chart. I'm sorry. Okay. So this dotted blue line, not screening. The green dotted line, it's screening. And screening is beneficial until we go over 62 euros by determination or measuring of ceruloplasmin. So this is just an idea. If we use this model at present in all labs, it would be cheaper than 61 euros. I've included these from a publication with the Spanish cohort. In our cohort, ceruloplasmin is very useful when we use this 11.5 threshold, but 11.5, the specificity and sensitivity is pretty high. And again, this is another discussion point, which is the threshold 20, 18, 15. 12 and 18 are the most complex cases for the diagnosis. The other important factor is the prevalence. So we're talking about rare diseases here, and probably will be accepting that this disease is not so rare. So a screen test is cost effective if it's frequent. If we're talking about 1 in a million, if you have to perform 1 million people only to diagnose one person, that's probably not cost effective. These are some of the charts that this model generates. It's not worthwhile only for one case. You can modify the prevalence and see at what point it stops being cost effective. In the Canary Islands, because of this estimated prevalence, it's cost effective. When the prevalence starts to fall, the costs start to rocket. And we have the y-axis, and these are high numbers, but it's regarded until up to 30,000 years by quality would be, it's cost effective and can be assumed by the public health service. One very important factor is prevalence, as I said, how frequent it is, the disease, I mean. Do you remember? Well, I can remind you that we were discussing other years whether prevalence is 1 in 30,000, 1 in 6,000, as we usually calculate in the Canary Islands. What's the real prevalence? It's very difficult to determine. And last year, if you remember, I was telling you the penetrance concept. Penetrance in a gene condition is like, I have the mutation, but I don't have the disease. What percentage of those with the mutation develop the condition? And well, we can assess that following up the patients with the mutation, what type of clinical signs they have. If they are severe, well, it's highly penetrant, that mutation. There are some indirect ways and inverse ways to sort of calculate that low penetrance. In this headline here, or this title, I'm not sure if I'm going forward or backwards. So, on the headline, this is the hypothesis that we have undiagnosed cases. Last year I presented some Gran Canary Island data from our cohort. We can complete this data with more reliable data because these have been obtained in the Spanish registry of liver disease, where we can find Wilson cases. Dr. Mariña talked about 410, but these data were drawn from the first time, and I think we were talking about 350 there. But then one way of seeing that we're missing many diagnoses is using the number of homozygotes present in one cohort and comparing them with the estimation if we had this mutated allele in the general population. Just to summarize, here's the estimated, and on the right-hand side, the registered. For the 1069, the European in the registry, we had 8, and the calculation tells us that it should be around 20. So we're missing a few. The leucine proline in the Canary Islands, which is quite penetrating, we have 24, and the estimation should be over 60. So we're missing a few, but maybe this is acceptable because of the limitations of this mathematical calculation and the Spanish registry, because they cannot always identify all patients. And then we have 2 other interesting mutations in this Spanish registry. So, MET645ARG, this is a highly frequent mutation in the Spanish population globally, even in the Canary Islands. And in the Spanish registry, we only have 6 homozygotes. So, if it behaved like the top from the top, it would be 18 to 20, the estimated one. But we have over 1,900 estimated cases. And I repeat, this is an accepted and validated methodology, but, well, there's a huge difference, and that's quite striking. Where are all these people, all these patients that theoretically have both mutations, and we haven't found them? They don't go to the doctor. It's the same, although it's not so interesting, because there's not too documentation on this mutation, the GLI869 arginine. The last one, basically those patients, if they have been diagnosed, well, this is a rare disease, okay, we're not well aware, we're missing patients, but maybe some patients have this mutation and this condition might be milder, not so striking, we're not so aware of it, and people just live their lives and they don't go to the doctor. We performed another calculation with the heterozygotes, and the results, we have many numbers here, but for example, I'm focusing on this one, using the allele, the MET645 arginine. It's highly frequent in Spain, and it's highly representative of the Spanish population in general. Well, according to this methodology, we should find more than 10,000 patients. And I repeat, when this study was done, the registry had only 350 patients. So our conclusion is that, again, there are people with these 2 mutations that don't go to the doctor. The first hypothesis or idea is to think that the disease is so mild that they might never go to the doctor. Because the doctor might tell you, yes, okay, your transaminases are pretty high, but you don't need anything, and they don't look further. So how can we prove these hypotheses that not all mutations have the same damage in our bodies? So instead of these theoretical calculations, what we did was a clinical trial of these patients with these 3 mutations that I mentioned about. Are very interesting because they give us different information. On the left, you can see the methionine arginine, which is the one that we consider the least penetrating, and on the right-hand side, the European, the 1069, which is acknowledged as 100% penetrating or completely, and the Liu Pro, which we have in the Canary Islands, and we sort of studied the clinical signs in the Wilson's disease. It's considered as severe when it has neurological manifestations, extrahepatical when we have the KF ring, so a number of clinical data that are associated with severity. So when we compare those that we regard least penetrating with the other 2, overall, in spite of having small groups, we're talking about 22 patients, overall the neurological manifestations were less frequent with methionine arginine than with the 1069 or the 708, and that was the case. The KF ring associated with the neurological manifestation was less frequent in the methionine arginine, and cirrhosis on diagnostic, basically advanced liver disease, was not very frequent in methionine arginine and more frequent in 1069 and 708. And this is the same with homozygotes. Since we have smaller groups, we couldn't find a statistical significance in any of these parameters. So penetrance is not the same. That's what we have to conclude. So the calculations that we use for cost efficiency, which is which in turn is going to help us to determine whether or not we're going to establish this screening, we need to revise that, to check that up. We need to be cautious because these findings that we find in our countries, and things might be different in other countries, in Poland or Austria, there are lots of mutations of 1069, but there is no 645. So back to the ceruloplasmin issue. Well, it's not highly penetrating, but since the person doesn't develop the disease, that's why we're not diagnosing it. So what we've seen after revising all these patients in the registry, we have 45 patients with methionine arginine associated to a different mutation, because we only found 6 homozygotes. But ceruloplasmin, which is one of the first diagnostic tools that we have, was highly pathologic under 15 in all but 3. We have only 3 cases that would fall under this group that we are missing because ceruloplasmin level is okay, and they determined that there's no Wilson. Although the conditions are less severe, according to this registry, the Spanish registry, they shouldn't be missed. And that's part of the message that I want to give you here. In terms of the screening, population screening is the mutations, all this data, it's a summary of the information from the Spanish registry. And I intend to show you the breakdown by regions of all these different mutations that I showed you. There's one that is only typical from the Canary Islands, and you know that I advocate for genetic tests. These tools are necessary. It doesn't need to constitute the basis of the diagnosis, but it's very important. And slowly but surely, as we get more and more sites and colleagues, and we use the genetics more and more, we will improve the quality of the data of this mapping. Now, since we're here in Valencia, aside from the three that I mentioned, we have one that is called promoter. I think it's been mentioned this morning. The promoter mutation, sometimes we don't know if they are not in the rest of Spain because they are at the beginning of the, they're not in introns or exomes, and we didn't catch it. The Valencia and the Catalan group, they're working with the Carmen Espinosa group, and we work together with them. We found quite a few patients with the promoter mutation. We don't know if you don't have them here because the origin is in Sardinia, and they went through the migration through the Kingdom of Aragon to all the way down to the Canary Islands. But anyway, who knows? Another way of diagnosing is to try to bring down the costs just doing a few exomes. And anyway, I'll skip that. And I told you last year, and I think Dr. Tugores has just mentioned it as well, that one of the tools that seems to be quite useful for the neonatal screening to be able to identify all Wilson's patients is detection of peptides in dry bloods. This Hill test that it's being done for other type of conditions. We are working with the CITL group. It's been described. We are committed to include 50 patients, but we are still missing 21. We have 29 so far. This is the last case, a patient and a relative that we need. Also carriers and healthy patients, people with the two chromosomes mutated, and healthy patients. And we hope that next year, we hope that maybe in 1 year we can find you some more definite results. And thank you very much for your attention. Here's the group of cooperators from all the different hospitals and labs. Thank you very much.